All right, everything seems to be on the screen and working. So yes, as Gemma said, my name is Luke Hassan. I am a dietitian. I've been working in the POTS, autonomic dysfunction and invisible illness space for 4 years now, and it's my pleasure to lead a team of dietitians who focus solely on this area. And it's a really important area of nutrition, one that's really under sort of done by dietetics at the moment, and we're really working hard to change that. So, just some acknowledgements first. I really want to thank Mel for being there in the room with you all today, and she's helped me put together this presentation too. Um, and I just like to make sure everyone knows that while we've scoured the research to really put together what we do as dietitians in this space. Unfortunately, as with many areas of medicine and allied health, we're still in the infancy of research on POTS in nutrition itself. And therefore, many of the discussions that we're going to have today will be based on the experience that we've had in the clinic, as well as that research that's slowly but surely coming together. So today, this is just a brief overview of the topics that we're going to discuss. Um, as this is a consumer, I guess, patient focused conference, I really want it to be I really want there to be a practical outcome today for all of you. I want you to walk away with some tools, some strategies, as well as some knowledge about nutrition in POTS. And we'll start by talking about why helping someone achieve a solid nutrition intake in POTS is really important. Then I'll briefly introduce you to a tool that we've set up to help people decide whether getting some help with their nutrition from a dietitian is the right move for them. And then I've got a couple of activities for you, as you may have noticed when you sat down on your tables, just to give you an idea of what we ask our POTS patients to do, as well as some of the foundational education pieces that we provide our patients when we assist them with their nutrition. And Mel will help facilitate that when the time comes. And then the talk will conclude with a case study to give you an idea of practically what this has looked like in the case of a patient. And then I'll open up the floor for questions. I'm hoping to be able to give plenty of question time. So I will ask you to hold those until the end. Scribble them down or type them out in your phone. Make sure they're ready for that time. And of course, um, we do have a limited amount of time today, and unfortunately, that means we don't have time to go through absolutely everything I would have liked to. However, I do think we've picked some topics that will be really important for everyone with POTS. Though I do definitely recognize that there's a variety of experiences and symptom presentations within the POTS, the autonomic dysfunction, and the wider invisible illness community. And definitely there's going to be that in the room today as well. And that means we're really only scratching the surface, but hopefully, as I said before, you'll walk away with some things that have been helpful, not just education, but some tools and some strategy as well. So I think it's really important to start with this question. Why is it important to talk about nutrition as a part of POTS management? And to put it really simply, our bodies need adequate nutrition and hydration to work optimally. If this isn't taken care of, our function is impaired, and this is especially true in the presence of other chronic health conditions like POTS and our chronic invisible illnesses. But more than malnutrition prevention, modifying how and what we eat can really assist with the symptom management in POTS and autonomic dysfunction. Of course, we have hydration and salt, and we'll talk more about them in a moment, but these are really strategies and education best delivered by a dietitian because we can really dive deep into what a person is consuming on a day-to-day basis and the variance both within and between days. We can go into that detail that allows us to give patients the most confidence about how to use salt and sodium in their individual circumstance. And this is really important because, as you'll all be aware, the general health messaging about sodium consumption is quite opposite to what we provide people with POTS. It's not just hydration and salt though. The gastrointestinal symptoms in POTS, so things like low appetite, getting full really quickly, nausea, bloating, abdominal pain, and altered bowel movements. they're likely to respond less favorably to regular nutrition intervention that we'd normally provide for these symptoms if autonomic dysfunction and other barriers to impact intake that are present in people with POTS just aren't addressed. This slide is the obligatory triad, pentad, septad, whatever you want to call it, slide. All the comorbid conditions to POTS and autonomic dysfunction have their own set of nutrition implications as well. And they can be missed and downplayed or maybe put as less important than some of the other symptoms of these conditions. So it's really important that when someone is really struggling with food and nutrition and they have one or more of these conditions, particularly when they've got multiple, they get some help for this because these nutrition related issues really are amplified at the intersection between POTS and autonomic dysfunction and these other conditions that you can see on the screen. So that leads us to our next question that I want to answer. How do you know when it's time to see a dietitian? Well, this is a resource that our team has developed to help people understand what some of the POTS and other invisible illnesses could be causing them to experience that's related to food and nutrition that could be making that a real struggle. Or could be making like different foods and ways of eating foods more difficult for them. So as you can see, there's a lot more on this slide than just gastrointestinal symptoms. So some of the main barriers to food that can be present for people with POTS can actually be more cognitively and sensory related and can make access to food challenging. In fact, access to food is really the part that we need to work on first. As I often say, there's no point me telling you what to eat if you're struggling with the how of eating. Some other considerations as to whether someone with POTS needs nutrition input are on the left there. And of course, how could we have a presentation by a dietitian without the classic Bristol stool chart in the top right? If you see a dietitian, be prepared to talk about your poo. It can tell us a lot about how your body is working to digest and process your food. And in the bottom right there, you can see the back of that resource that I just showed you on the previous slide. And we like to say that if you're ticking 4 or more of those boxes, you'd probably benefit from seeing a dietitian to help with your food and nutrition. Okay, we got here very quickly, which is good. We've got some activities. Let's get on to these practical things. As I said before, since it's a workshop, I thought I'd bring a few things or I'd get Mel to bring a few things now and take you through these activities. Just sharing some of the most common POTS eating strategies and considerations that we teach to our patients. So there's a few different topics here. We're going to start with hydration. The recommendations for hydration might vary slightly between people, but really that 2.5, 3.5 liters of fluid should be pretty adequate for someone with POTS. Obviously, that's a very general recommendation. But how do we really go about getting there? Right? Of course, we know how to drink. We know that it's important to drink consistently throughout the day. We don't want you drinking all this fluid at once, please. And that's good and well to know. But many people with POTS have plenty of barriers to drinking, whether it be flavor, whether it be texture, whether it be remembering to drink and object permanence, whether there's actually issues with the neck, upper neck hypermobility, or even finding that you're always running to the toilet when you continue to try and drink more water. Some of the strategies for those various issues are mentioned or on the slide in pictorial form. So I guess the first thing for me, if one type of fluid or another is getting boring or repulsive, there are plenty of other types that can be used. And let's try and choose the things from the hydrating fluids column on the left of that table. But if neck pain and neck hypermobility are an issue, then maybe we actually want to get a water bottle with a straw so that we can not crane. That's one example. There are plenty of other examples out there. And on water bottles, actually, there's bottles out there that you can buy that have this Bluetooth technology that links to your phone to track how much you've drunk over the day and remind you to pick up that water bottle and actually drink at different time points, which I think is pretty cool. And it's been something that patients who have engaged with that particular strategy have found that super helpful, particularly when they just struggle to remember that water is something they've got to do throughout the day. We've also recently been introduced this really cool product called Vital Zing, which is just they're simply flavored water droplets. So you just drop a couple of drops of this stuff into your water. There's plenty of different flavors depending on what you like. There's no electrolytes in them. There's no carbohydrates in them. It's literally just flavoring. And this has been really helpful for some too who maybe they are getting enough salt in, which we'll talk about in the next slide. Um, but they really struggle with their fluid and need something that's flavorful, or they've got really particular, taste or sensory complications with actually getting fluid through. This can be a really helpful product. If you would like to try some, there's some actually on the back of the lectern there that Mel can help you with after the presentation is done. Okay, so let's talk about sodium for a little bit. And this is actually where I'm going to get a bit active with this. So in a second, we're going to do two activities on our tables. So you won't have to get up and move, but there's some pieces of paper on the tables with some activities. In a second, Mel's going to get up and start handing out little bags with salt in them. So Mel's measured out 2 teaspoons of salt in each of the bags that the table is going to receive. And as you can see on the screen, this is about the beginning of the amount of sodium we would like our POTS patients to get to when they need extra sodium to assist with their symptoms. So once I finish explaining, I'm going to give the room 1 or 2 minutes to actually have a go at two things. So some people can have a go at our salt the food activity. So using the salt in that bag that Mel's just handed you, I want some of you to take a shot at adding what you would consider to be a reasonable and importantly, a palatable amount of salt to the sheets of paper provided to the meals on the sheets of paper provided. At the same time, some of you can have a go at our other activity, salty foods. So have a go at trying to rank the foods on the page from 1 to 6, 1 being the most salty and 6 being the least. And I've got the answers to this on the next slide, but I'll give you guys 60, 90, 120 seconds to do this, and I'll be quiet for a moment and I'll call you back to when I've given you that time. Thanks, Gemma. I can't hear you all without the microphone straight up, so thanks for getting that in. I hope that was a bit of fun for you all and broke up the talk a little bit. I'll get to the answers in a second, but I just want to talk about the salt a little bit first. So I think we can all agree if we're trying to just put that 2 teaspoons of salt on our 3 meals a day, that can be quite a bit of salt, right? Like there's quite a bit of salt in that bag. And while we give these targets, that 4 to 6,000 milligrams a day, 8 to 10 grams of salt per day, there's 2 teaspoons per day, whatever metric we use, it's less about actually getting to that metric straight away and using it as a goal, right? Getting to a gradual increase in sodium intake in accordance with how much salt someone's already consuming, with what their taste tolerance is, with how well they actually respond to the extra salt intake in terms of their symptom management. Those things are really, when I'm sitting down with a patient, they're more important for me than the numbers. The numbers just provide a little bit of an objective goal to it. And in accordance with that, there's no need for me to get a patient to actually be hell-bent on calculating how much sodium they're taking in every day. Exercises like the ones that you have just done and knowing a little bit more about, okay, well, how much salt, and I have the bags for reference here, but it's like if I'm getting through three-quarters of that bag or half of the bag each day, well, I know I've got a little bit more room to go, and that might take 4, 6, 8, 10 weeks for the person to become more accustomed to that amount of salt in their diet, and then it's actually mirroring up. Okay, well, I'm increasing that salt intake and by proxy the sodium intake, and how's that actually impacting my symptoms? That's really the metric that I want to know. You know, often people get given a particular number before they come to see us, or they're just told to, you know, consume more salt, but they don't know what that means. So these activities and the resources and the things that we've just gone through actually put this in context for patients. Now, I really want to make note, if a patient's having any sort of difficulty with salt intake, they should really go slow, as I said before, slow and gradual with the increase. As a big bolus of salt in and of itself at once can cause gastrointestinal symptoms, as well as make the palate feel pretty funny and turn people off their food. So there's a very fine balance, and it can be really difficult for some people. So this is the importance of getting some solid professional individualized advice for this, if they're having any difficulty with it whatsoever. Um, and if you are getting the 2 teaspoons in relatively easily, and if you're also getting some electrolytes in, because of course, um, it's just having salt in that form that you've got on your tables is not the only way that we get sodium in. It means you're getting closer to that 6,000 milligrams, um, which, you know, somewhere within that 4,000 to 6,000 milligrams of sodium a day is generally where we're going to start seeing a decent improvement in symptoms, or maybe getting towards the maximum end of improvement for symptoms. We don't want to push it too much more than that. Some of my patients will, and of course, we're being really mindful of some other things regarding their overall health when we start to push out our sodium intake a little bit more than that. But most people are perfectly fine to tolerate that, and will just excrete any extra that they don't need. Um, and with that said, it is important to note that each person with POTS will need a different level of salt to be helpful for them. Um, in terms of other ways to get salt in, there's this resource that I've left up on the screen here, which Mel's created, which is actually a book of electrolyte recipes in like little mocktail recipes, which is fantastic. Um, yeah, it's such an awesome way to get more sodium in and be a little bit creative with it, and can make it pretty fun. Um, yeah, so if you're interested in that, you can talk to her about that. Here's the answers. Some of these answers may surprise you a little bit. We always get, you know, people coming and being like, "I have salty popcorn as a snack," and that's cool. But it's definitely not the most salty thing that we can have. There are some other options that, yeah, really blow it out of the park. Same with pickles. Everyone's on pickles for saltiness, and olives too. But even a can of John West tuna, that can be more salt and more sodium than what some of those more snacky things are. So interesting food for thought, so to speak. Right, two more eating strategies, and then we'll go into a case study. So we're going to come off the excitement of all the salt and sodium related things and actually talk about resting for a moment. So as I talk through these questions, I just want you to take 20 or 30 seconds with me to think about what each of these questions, statements, whatever you want to call them, actually mean. So let's just think about what quality rest is. When in your day do you feel at rest, or like you're being restful, like you're restoring some of your energy, whether that be physical, emotional, cognitive, social, environmental? And you know, this might be pretty self-explanatory, but what's the purpose of that rest, right? In terms of living with POTS, living with an invisible illness, what does that rest allow us to do? And thirdly, what does a restful activity look like? Now, this is going to be different for every person, but if you can just take a second to picture a couple of the things that you do that you find restful. You know, for me, um, I'm an avid golfer, so getting out onto a driving range and hitting some golf balls, while it's not physically restful, it's not really physically tolling, but it's certainly cognitively and emotionally restful for me. So when we talk about resting around meals, we're actually trying to get the body into a state of what we call parasympathetic nervous system rest. Now, this is very surface level sort of autonomic nervous system physiology. But if we're thinking about the system that's really driving our food to be digested and absorbed and allowing our gut to work the best that it can, it's your parasympathetic nervous system. Now, unfortunately, people with this autonomic dysfunction sometimes have difficulties engaging this part of our nervous system. So we want to be really purposeful before, during, and after our meals in actually engaging this part of our nervous system and allowing our body to do the work of digesting our food as best as it possibly can. So what we generally get people to do is actually try and engage in quality rest or restorative practice for a few minutes before our meals, during our meals, and then for a period of time after our meals. Could be anywhere between 10 minutes and an hour, depending on a whole bunch of factors in that person's life. And we get them to actually do what we call a green time activity while we're doing that, while we're taking that rest. So we're not just sitting there waiting for the time to be up. We're engaging in something that feels like it is physically restful, it's cognitively restful, it's emotionally restful, and it's sort of environmentally, socially restful. Now, the definition of this green time activity to me is a single task where the outcome doesn't really matter. The classic example that I use for this is watching a sports team. So, if you are sitting down watching a sport that you enjoy, then that might be a single task. But if you're watching your sports team, then the outcome definitely matters. It's not really going to be a green time activity, is it? Depending on who you are and what sport you go for, really might not be a green time activity. So we want to think about some examples of those things and how we might actually be able to play that out around our meals. Your main meals, probably the more important part of probably the more important time. You know, the lower volume of food that we have, the easier it is for the body to digest and absorb that food. So it's generally our larger meals of the day that we're trying to do this around. Um, but this can be a really effective strategy at reducing not only gastrointestinal symptoms around our meals, because we're allowing our gut to do the work properly, but also reducing some of the cognitive or brain related symptoms that we can get around meals. I don't know if you've ever sat down for a meal and then sort of recognized that afterwards it was a little bit harder to think. You felt really sluggish and slow. And this can happen with anyone, but it tends to be more pronounced in our autonomic dysfunction population. So actually engaging in this rest, allowing your body to do the work of digesting and absorbing, can be really powerful to reducing those symptoms that we can get around our meals. There are also blood flow implications to that as well, which I'll briefly touch on next. But I just wanted to touch really briefly on the carbohydrate considerations. It's a really hot topic in sort of managing POTS at the moment, and there's a lot of opinions on what people should do with carbohydrates when they live with POTS. Some people just say you should cut it out entirely. Some people say you really need to go low carbohydrate. You'll probably get a gist of the position that we stand in, based on the evidence and what we've seen in our patients and how they respond to things. But you can read on the screen. These are some of the reasons that carbs can be difficult. I've actually done a presentation with Mel in the past, and we spend a full 16 minutes diving into um, the information that we currently have on carbohydrates and how they impact the body with POTS. So if you're looking at more information on this, I'd highly suggest you go and watch that presentation. It's just listed at the bottom of this slide here. But there's a few things that are really important. I won't focus on the information too much now because I want to keep this practical. But And there's a few things that are really important to know. I think carbs are not inherently evil. We need them for energy for our body. There are some people who do okay without carbohydrates, but I find that those people are um, very few and far between. And for the vast majority of people, having some carbohydrates in your diet is going to be a better way to go. Um, and there is a way to combat the potential impact of carbohydrates on the POTS body, um, on how it feels in the gut, on how we feel in our heads and our autonomic symptoms after this. And the way to do that is to make sure that our meals are as well rounded as they possibly be. So where we find people have the most issue with carbohydrates is when they're having very um, when carbohydrates are the main portion of their meal. And by main portion, I mean 50, 60, 70, 80%. It's going to differ for every individual, but when that's the vast majority of what's on their plate that they're consuming, um, and when those carbohydrates have the ability to digest and absorb quite quickly, which is known as a higher glycemic index food, and when we're consuming a lot of them at once. And again, that's going to differ for each individual, but this means we're having a high glycemic load of carbohydrates at once as well. And what happens when we have a more well-rounded meal, when we pair our macronutrients on the plate, is it takes longer for the body to actually digest and absorb those carbohydrates, longer for those things to break down and stop some of the things that are on the slide, at the top of this slide, from happening as quickly in the body so the body has more time to regulate. Now, sure, we could take them out of the equation. We could simply have smaller meals in general, and that would also help as well. But if we're looking at trying to get, fairly regular standard meals in our day and in our throughout the week, so we can try and get the best level of nutrition into our body as possible, making sure that we have a decent amount of fiber or roughage, fat and protein in our meals. And you can see the image on the slide. There's a bit of a breakdown of how it can be done. And this is a really good place to start. In fact, the place we start with most of our patients to try and separate our macronutrients on the plate in that way, and then work from there based on symptoms to allow them to try and get some more control over how their body responds to carbohydrate containing meals. And something I've been really pressing with patients and suggesting that they do is actually to consume some fiber, some roughage in particular, before they start on the carbohydrate portion of their meal. And that's been particularly successful for me recently in my clinical work. Practically, for meals, meals are generally going to have a lot of these components, but snacks is where I find a lot of people get tripped up. So some practical application of this with some snacks is if you're going to have some fruit for a snack, make sure it's some fruit with some skin, again, roughage, or maybe we're coating that fruit with some peanut butter, another type of nut spread. Um, if we're having some like sort of cereal for breakfast, we might choose to have some higher protein yogurt um, with some muesli instead of just having the cereal itself. If we're finding that this is an issue, we might also find that having some protein powder in your morning fruit smoothie would be a good way to pair these things as well. And it's important to note that these symptoms around carbohydrates in our clinical experience, they've been much more likely to present when people are not managing the other considerations of POTS and eating. So when they're not doing their hydration and salt properly, when they're not resting around meals, when we're having really intermittent eating occasions, it all goes together, and it all has a cumulative effect. So really briefly, I've got a case study for you. I don't want to take too long on this because I recognize the time. Um, but I thought I'd take you through Miss Z. So Miss Z has POTS. She has chronic fatigue syndrome. She's hypermobile. She has endometriosis, polycystic ovaries, um, premenstrual dysphoric disorder, anxiety, and is currently getting a workup for ADD, ADHD. Um, Ms. Z really had issues around, what they thought were food intolerances. So there's several sort of non-specific food intolerances that existed. Ms. Z was able to match up a few of them with fermentable carbohydrates or FODMAP intolerances. Though surprisingly, they didn't always match up. Like fermented dairy was tolerated, and we wouldn't normally expect that to be tolerated with FODMAP intolerances. And it wasn't just the FODMAP foods. There were very non-specific foods that seemed to make Missy feel really sick. And she'd sort of admitted that it was just guesswork, but wanted to stop having to guess, which I think is very fair enough. Missy thought that this was going to need an elimination diet to sort out and wanted to know how to implement one, especially knowing that she already had restricted food intake and was already quite concerned about that, which again is very fair enough. And this patient had been all over our socials, and it had family members who had also attended active health clinics. So she knew there were some key things already that she could do from a food and hydration perspective to help manage her POTS, and really wanted to know how to optimize this. So again, this is what a dietary assessment looks like. We go through um, anthropometry, so if the body's been changing, we go through biochemistry as well, so blood tests, poo tests, any sort of scopes that have been done. We need to know your medications because there are some interactions with food, but also medications can change the way we poo, they can change our appetite, they can do a whole bunch of things to the way we are able to eat food. And then we've got these gut symptoms as well that you can read. Um, all of the classic Potsy gut symptoms and all of the classic invisible illness symptoms on the right-hand side of the screen there. We then, of course, need to know what your diet looks like, being dietitians. And this is what Miss Z's diet looked like. She was eating like not a not a terribly small amount of food, but still well under what she needed to eat to be adequate. And her diet was very, very restricted. She probably could have drank a little bit more fluid as well, and that's represented in what we call our nutrition impressions. So Miss Z presents with poor oral intake, as you could see on the last slide, relating to an attempt to avoid gastrointestinal symptoms in the setting of food intolerances, so FODMAPs and others, as I explained, and POTS. And then we had the evidence there that showed that. So this is really briefly what a diet assessment will look like. And then in terms of a plan for Miss Z, this is what we wanted to do. And this is a really common case of someone who presents with POTS, um, but also with known food intolerances. And both POTS and food intolerances cause gut symptoms. And this can present a question to a dietitian and to a patient, right? Where do we start? What do we start doing first? And most dietitians will probably start with the food intolerances and managing that side of things since it's what we know. Um, but I prefer to go the other direction. And this is really the culmination of what we like to do with POTS. Working on POTS eating strategies first can help us to impact the nervous system, help us to down-regulate that nervous system and allow the parasympathetic to come through and really do its work in helping with digestion and absorption. And help some of the key systems that are experiencing the impact of autonomic dysfunction. And this decreases how threatened the nervous system and the body feels to food and food components entering in, and it turns down how sensitive those nerves in our gut are going to be. And this can yield fantastic results. And sometimes it's actually not necessary to restrict food intake further to achieve less symptoms when we use this. Sometimes we need to combine those strategies with intolerance investigations, and the key here is really to never restrict more than we absolutely need to. And of course, in doing all of this, we want to try and achieve adequate nutrition as well. I'm rushing through because I recognize time, but it is important that we also have some view of other things that can be helpful for these symptoms as well, and that gut-directed hypnotherapy and advocacy work with other appropriate professionals can be really powerful for that. So this is actually where Miss Z ended up in January. That's what they felt. And this is what it meant. Um, so they were able to really decrease their food restriction, better identify their non-food triggers of gut symptoms, which are a thing. The POTS eating strategies were all put in, and there was more consistent eating occasions with more variety, which is really what, in the first instance they wanted to achieve. Again, there's some further learning there if you're interested, and there's some references as well. If you want to get in touch, there's my details. So feel free to ask Mel about them, and I will stop the slideshow and sharing now, and we can talk questions for a few minutes.